Can you all see my screen? Okay. We'll just start here. All right, so the topic we're going to talk about this week is attention deficit hyperactive disorder. So there's three types. Do you guys remember the three subtypes? There is what?
Mm. Inattention,
There's predominantly inattentive, right? And what's the other one?
hyperactivity,
And then there's mixed.
mixed.
A lot of times kids will fall into the mixed. I mean, I rarely ever see, well, it's like one or the other. It depends. Especially if they have a comorbidities like oppositional defiant disorder or chronic disorder. I mean, it's kind of like buy one get one free. A lot of times they'll have the criteria to fit those diagnoses as well. So these are just a nice. This is a nice breakdown of the different options that we have. Right. So the first option we're going to talk about is stimulants. Right. Why do you think a stimulant works for ADHD? Is it a dopamine deficiency, or is it too much dopamine? What do you think? In norepinephrine.
Mm.
Hmm? Do you think it's too much or too little, or do you think it's a mix of both? It's actually a mix of both. All right. And it's hard to know the subtypes if someone has ADHD predominantly because there's too much dopamine or ADHD because there's not enough. So a lot of times you might have to mix and match medications, right? So there's three main classes of meds that we use for attention deficit and hyperactive disorder. You have the stimulants, right? Which is there's two formulations, right? Two pretty much generic forms of it. You have the methylphenidate solutions, right? Which Ritalin falls into that. And you have the amphetamine solutions, right? Which is the Adderall. When it comes to amphetamines, you have isomers. You have so the D and L isomer of amphetamines, and you have the mixed amphetamine salts, right? Which is like 75%, 25% mixed in isomer. So you have one that's like equal D and L. You have one that's just D, and you have one that's 75% D and 25% L. Clinically, it doesn't really matter. I mean, sometimes patients might respond to one more than the other, but you can ask if there's like a family history. Usually there is, like my mom or my dad or my cousins or my brother or sister have ADHD, and you can ask what medications they've done well on. So if I know that from history they've done well in this formulation, I probably will most likely go with that formulation, right? Or if they've had side effects, let's say from one formulation, I probably won't go with that. Right. So you have stimulants, which are broken down to amphetamine solutions and methylphenidate solutions. You have what's the other class? It works on norepinephrine. What? Alpha blank. What?
Like an alpha 2
Antagonist
agonist.
or agonist? Alpha 2 agonists, right? Which right now there's a bunch of alpha 2 agonists, but for ADHD, we use clonidine or guanfacine, right? Those are two alpha 2 agonists. And the next class that are non-stimulants are called norepinephrine reuptake inhibitors. And right now, there's only two that's out in the market in America. There's viloxazine, which is a brand name Quelbree, Quelbree, and you have atomoxetine, which is brand name Strattera. All right, so I'll repeat that again. You have the stimulants, which tends to be first line, has the highest effect size, which is usually one or higher, right, which is very effective. You have alpha 2 agonists, which effect size between zero point 0.4 and zero point 0.6, and you have norepinephrine reuptake inhibitors, which is about the same. All right. Usually we try to combine them because sometimes if you go all in on one, it might give side effects. I'll give you an example. If you go all in on the stimulants, it might cause worsening insomnia at night. So you might have to give them an alpha 2 agonist at night to kind of help put them to sleep and calm them down a little bit. What I'll try usually do is I'll try to bring down the stimulant and see if that works or dose it a little bit earlier or switch to an extended release version. If that doesn't work though, usually an alpha 2 agonist on top of that can help. All right. Because what are the side effects of an alpha 2 agonist like clonidine? Sedation. All right. So you can kind of tell the patient, as much as I do want to put you on one medication, but sometimes, two might be better than one. Because sometimes one plus one equals five, right? They're synergistic. So adding the alpha 2 agonist to the stimulant might actually give you more bang for your buck, and the stimulant might work better and give you better options. All right. Going to neuroanatomy just a little bit. What part of the brain is affected in ADHD?
In what? Sorry.
What
What
part of the
part?
brain is affected in ADHD? Temporal lobe? Is it the parietal lobe? What is it? Sorry, mute yourself if you're not on, Sarah. Yeah, okay. The frontal lobe, right? So the frontal lobe is dysfunctioning in ADHD, right? Because your frontal lobe is your executive functioning center, right? Your judgment, your personality. So your dorsolateral prefrontal cortex has to do with cognition. Dorsolateral is just the way it's So dorsolaterally, prefrontal is in the frontal lobe, cortex, part of your brain. All right. So that has to do with sustained attention. Sustained attention is what you guys are doing now, right? You're listening to me, you're keeping your attention, that's sustained. Now, there was a little sound before, and some of you might have gotten distracted, right? So that's called selective attention. So you kind of have to override that by using your anterior cingulate cortex, ACC, it's called anterior cingulate cortex, which is also in your frontal lobe, actually. So in order to have sustained attention and be able to withstand distractions, you need to have a functioning anterior cingulate cortex. So if I asked you which part of your brain is, implicated in sustained attention, that would be your DLPFC, right? Dorsal lateral prefrontal cortex. Which part of your brain is not working correctly in selective attention? That would be your anterior cingulate cortex. All right. There's other parts of your brain too that have to do with like aggression and impulsive behaviors. That's your orbital frontal cortex, OFC, orbital frontal cortex. And there is an affect component, even though it's not in DSM, but people who have ADHD sometimes have affect dysregulation too. That is not depression or not bipolar, right? And that would be your ventral medial prefrontal cortex, it'd be MPFC, ventral medial prefrontal cortex. Right, so dorsolateral prefrontal cortex, sustained attention. Anterior cingulate cortex or anterior cingulate is for selective attention, being able to filter out stuff that you don't need to focus on, like that noise from the background. And your orbital frontal cortex could be dysfunctioning if someone has aggressive behaviors, right? They could be impulsive, which happens a lot in ADHD also, which is why it's comorbid with a conduct disorder or oppositional defiant disorder, right? So what does the medication do? Well, it kind of fine tunes the brain. We try to give a little bit of dopamine when needed because you do need dopamine to kind of help with your focus, right? We do know from mood disorders that having too little dopamine can cause anergia, right? Avolition, low motivation, or concentration. So we kind of look at that as a dopamine deficient issue. So if someone comes to you with those symptoms, drive, motivation, you probably do want to increase dopamine just a little bit, right? What are some contraindications? Family history of possibly psychosis or family history of bipolar disorder, right? Mania. So if you go too high too soon, too fast, you might cause psychosis or mania. Family history of, Rob just should know this, is substance abuse, right? It has to do with how hard do you hit the nucleus accumbens, right? Which is the mesolimbic area, VTA to the mesolimbic area. If you give someone too much of a rewarding medication, right? Let's say, I don't know, they sniff Adderall, right? It's going to hit it so hard that it's going to be reinforcing. It's going to feel good. It's going to give you a euphoric effect. And what's going to happen? They're going to want to repeat that behavior, right? That's dopamine driven. And then they want it. So technically, dopamine is the drive and the anticipation of it. And just to be more clear, it's actually opioid when they feel good. The pleasure centers are opioid, right? We'll talk more about that when we talk about substance abuse, all right? So sometimes people will say, well, why are you giving someone stimulants? They do have a family history of substance abuse. Sometimes you can give it because patients who have untreated ADHD might try to self-medicate, right? Especially if they're in college, kids are getting prescriptions from other people and they're abusing it. They're using it, in ways that aren't supposed to be used. And when the patient takes it, they might feel normal, quote unquote, in the beginning, right? But then they take too much of a higher dose and it gets reinforcing. So what you want to do is you want to prescribe it. It's called harm reduction and give them a dose that works for them and helps them function in life, where they're able to focus and do daily activities, but not high enough in which it's rewarding them too much and they want to take higher dose and abuse it, right? So there's different formulations. So for my practice, I try to keep it simple. So if when you guys start practicing, I would probably recommend knowing one immediate release version of an amphetamine solution, whether it's dextroamphetamine, amphetamine, right, which is mixed amphetamine salts, immediate release, which can work between 4 to 6 hours. Know a long-acting version, whether it's Adderall XR, which is still mixed amphetamine salts but extended release, or Vyvanse, which is lisdexamphetamine, LYS. What's the difference between Vyvanse and Adderall XR? Do you guys know? What's the difference? What do you think? Why was Vyvanse created? What's the lis in the front of it? LIS. It's lysine, all right? So lysine actually inactivates the compound. So as long as that lysine is bound to the molecule, to the dextroamphetamine, which is dexamphetamine, the D-isomer of amphetamine, it's inactive. And the only way you can cleave that lysine off is actually ingesting it, right? It has to go through your capillaries and it removes that lysine. If someone tries to crush it and sniff it and snort it, it doesn't work, right? That's why it's very rarely abusable. And if they try to inject it, it doesn't work, right? It has to go through your stomach mucosa to your capillaries. All right. So that's why it might be safer for a medication who has a history of substance abuse or a family history of substance abuse. If you want to, if they do well on amphetamine solutions, why not Vyvanse? All right. It used to be branded only, so it was very difficult to get it pre-approved. So it was very difficult to get patients to get those meds. And then it was very expensive if it was off formulary. But now it's generic. So there actually is generic lisdexamfetamine now, and it's much cheaper. So cost shouldn't really be an issue. All right. So know that. Also know at least one immediate release of a methylphenidate solution. It's up to you. You want to do Ritalin IR, which is one of the original ones, right? That's a methylphenidate immediate release. And look, it only works about 3 to 5 hours. And then Ritalin LA, if you want to do 6 to 8. Or you could do an even longer version, which is called Concerta, CONCRTA, methylphenidate ER, which is Oros. What does Oros stand for? Anyone know? Oros. Is it that guy that hates Republicans who's giving money? No, that's Soros. Sorry. Oros.
It's osmotic release oral system.
Very good. So what does that mean?
It has different layers. There's like an immediate release portion, a sustained release portion, and then there's like water in the pill too, as well.
What comes out first, the immediate
The
release?
immediate
Very good,
release.
right? So it's made in a way that it's kind of smoother, so patients tend to have less withdrawal. So unfortunately, the methylphenidate, Ritalin, it's notorious for rebound for whatever reason. So usually people call it Ritalin rebound, which means that what is rebound? What does that mean? You tell me.
Like if you're treating something and it goes away and then you take the drug away, you'll get the like if you're hypertensive and you take clonidine away, you could get rebound hypertension. So you'll get
Yes.
the symptom back.
It could be symptoms, but it also can have other components too, like irritability, right? So they might be more irritable and angry when it's leaving their system. So remember, if you're what we talked about with downregulation, upregulation, even though it's short term, these are pretty potent medications. So your receptors are kind of like craving that medication. So once those meds wash out and your body metabolizes it, now you don't have dopamine or norepinephrine hitting those neurons anymore. So they're craving it. So what can happen is people might feel more depressed, they might feel more down, they might feel more angry. So usually I'll ask parents, how do you determine rebound from untreated symptoms? What do you think? How can you tell if it's untreated symptoms or rebound?
Just knowing what their baseline is and where they were starting from.
That could be one. And you can also know the pharmacokinetics of the medication, right? When is the onset? Is it a half hour to an hour onset? And how long does it typically last? All right. If the rebound is happening during the onset when the medication is supposed to peak, quote unquote, or the symptoms that you're talking about, then I would probably safely assume that it's probably due to untreated symptoms, right? You might have to go up on the dose. If it's happening during the 4 to 5 hour mark of, let's say, the methylphenidate, and that's when it's wearing off already, then you could probably assume that it's the rebound. Does that make sense? So just know how the medication works. When does it kick in? When does it peak? When does it start to wear off? And then you'll know if it's rebound, if it's around that time. That happens a lot with sometimes with insomnia. Because I know sometimes we think that insomnia has to do with being too high in the medication, but insomnia can also happen when ADHD is uncontrolled. If patients are hyperactive at night because the ADHD is uncontrolled, they actually can't go to sleep either. So it's very difficult. You might have to tease it out, find out. Is it insomnia? Sometimes I've treated insomnia actually by increasing the ADHD medication. So it lasts until they're about to go to bed. And then by the time they go to sleep, the medicine already wears off. Or I might add clonidine if I'm not sure at night. So there's a little bit of finesse. You might have to finesse it a little bit. That's where there's an art and science. But you want to finesse it to a point where you understand the mechanisms of the meds, right? Not just trial and error. All right. So if it's happening during when the medicine were wearing off, maybe it could be due to, the rebound of the meds or the fact that the ADHD is kicking in at night and the patient can't sleep. You couldn't add an alpha-2 agonist. That could be a good option. Or you could increase the dose if they don't like the alpha-2 agonist. I had a kid that you give them alpha-2 agonist, the side effect is constipation. They've already had really bad constipation, and it hurts them when they use the bathroom. So the mom was like, I don't want to put them on clonidine or guanfacine again. All right, let's raise the stimulant. And it actually worked. So how I usually do is when I do start a patient on a stimulant, especially with kids, I'll actually start immediate release first. All right. When it comes to adults, I usually start with an ER release first. With kids, I do IR first because kids can have something. What is it called when someone gets a medication for something, but they do the opposite of what the medicine does? What is that called? Starts with a P.
The paradoxical.
Very good. Paradoxical, right? So you'll see that sometimes with antihistamines, with kids who have autism or kids who have intellectual disability, you give them antihistamines and it disinhibits them. Because remember, you do need histamine. We'll talk more about that when we talk about sleep. Everyone knows about antihistamine, but people forget that histamine itself is a stimulating agent, right? It's what keeps your brain awake and keeps you alert. So antihistamine blocks that so people fall asleep. But what about histamine release itself? It actually is, a molecule that keeps you alert and awake. So we do have some medicines that increase histamine, like modafinil, which is used off-label for ADHD also, um, that can help people stay alert. So paradoxical effect. The way I avoid that is I give them immediate release first, and I tell the parents, let's give little Johnny, I don't know, Ritalin 5 milligrams on a Saturday when you're home from work, and I want you to let me know what time does it start working and how long does it start to wear off. Right? Let's do that for a week. I'll give you a week's supply. Okay, well, it starts at around 10 o'clock. I gave it at 8, so it took about 2 hours, and it started wearing off around 3 o'clock. All right, I'll tell you what, let's do 5 milligrams in the morning, but then at lunchtime, I want you to give him another dose after lunch. Let me know when it starts to wear off. All right, we do that again for a week. So it might take maybe a month. And of course, the patient will have to do some homework. I mean, the parents have to do some homework. But the good thing is you're being as precise as possible. I don't believe in giving people like a 2 week supply and say, come see me in 2 weeks. And, we have to increase it or we don't, right? That's very sloppy. And I don't like to do that because then you're wasting meds that are controlled and there's a shortage of medication right now. So in order to be proficient and cause less suffering for the patient, and remember that if a paradoxical effect happens too, that's what I tell the parents. If a paradoxical effect happens and within 2 or 3 hours they're hyperactive and they're aggressive, rest assured in 2 or 3 hours, once the meds wears out, it'll be gone. And the parents feel better about that. If I give them an extended release right away, number one, it's sloppy and I don't know what their dosing is going to be. And if they have a paradoxical effect, the parents are going to hate you because the kids are going to be rock and rolling that whole weekend, ruin the parents' weekend. I've had that happen to me in the past. So don't do that. All right. And it's easy to convert because give or take, Concerta, which is a methylphenidate solution, ER, is equivalent to give or take, taking Ritalin 10 milligrams BID, right? 36 is equivalent to taking Ritalin 15 milligrams. You get the point, right? It's equivalent to that. If you look at the graph, the way usually when you take immediate release, it goes up and down like a roller coaster, right? Like this. If you do the extended release, it's a little bit more like that, right? Like one curve. It's cleaner, there's less profound rebounds, and patients tend to like it better. So as much as possible, I will use extended release. Some patients fall outside that, and you might have to use an extended release first, and then give an immediate release in the middle of the day. Because the thing is, if you go, let's say for instance, I've tried 27 milligrams of Concerta, right, which is methylphenidate extended release, and the mom is like, I don't know, they're just not sleeping, and they don't like the way it makes them feel, but they were doing okay in the 18, but it wasn't enough to get them through the whole day. A good compromise would be let's give them Concerta in the morning, right, at 7 a.m. And then after lunch, you give them a 5 milligram immediate release. And then sometimes that gets them through. All right. So you kind of have to understand. Another strategy could be adding an alpha 2 agonist at night. The good news about that is there's no stigmatization. They have to go to a school nurse at 12 o'clock and get a dose of the Adderall or methylphenidate. But the thing is, the alpha 2 agonists, like clonidine and guanfacine, might take a couple of weeks to work. So the downside is that it takes longer to work. The good thing is that it's less stigmatizing and they don't have to go to a school nurse at 12 o'clock, or the mom doesn't have to remember during the summer, or dad to give it to them in the afternoon. Does that make sense? Obviously, you could do the same thing with Adderall and methylphenidate. I mean, you can do the same thing with Adderall as you do with methylphenidate, right? Adderall IR, then you can do 5 milligrams Adderall twice a day. Have the parent let you know, and then you can switch it to Adderall XR if needed. It goes in 10 milligrams, 10 milligram XR, 20 milligrams XR, and so forth. All right, that's a mixed amphetamine salt. A little more advanced, once you start getting better at your practice, you can start using isomers. So what's the difference between dexamphetamine and L-amphetamine? The dexamphetamine tends to rely more on norepinephrine. It tends to be more potent, all right? And there are some people that respond better to the isomers. The thing is, the isomers are more expensive and sometimes insurances might not cover it right away. So I will try to use the cheaper alternatives, which is the mixed amphetamine salts first, and then see if that works for them. All right. Sometimes people need a little bit of D and need a little bit of L. So the D and L might work better for them. All right. If that doesn't work, then you can use dexamphetamine. So L tends to work more on norepinephrine, but prolongs it a little bit longer. D tends to work a little bit less, but works more on dopamine, which gives them a little bit more of that dopamine hit. All right. Sometimes they need a little bit of both and get the best of both worlds. There's also isomers of methylphenidate. There's dexmethylphenidate. The L-methylphenidate is inactive, so it doesn't matter. It doesn't do anything. That's why there's no medication. There's no L-methylphenidate formulation. Any questions for that? Kids tend to do better with methylphenidate solutions for whatever reason, if you look at research about that. And for some reason, adults tend to do better with Adderall solutions, amphetamine solutions. But my experience, I usually get a family history, and if there's a family history of ADHD, I ask what the family's used in the past, and whatever the family's done well in the past, I'll usually do the same. Right? I have siblings. One has ADHD, the other one also has it, and they're pretty much in the same dose of medication. Right? So the key point is making sure that you're prescribing. You don't want to overprescribe it, so you don't want to overshoot it. Right? Because if you overshoot it, they're gonna have anorexia, they're not gonna want to eat, they're gonna lose weight, the PCP is gonna hate you, the pediatrician is gonna hate you, and they're not gonna be able to sleep, right? They're gonna be lower in the percentile when it comes to their height and weight. So make sure you, especially if you're doing child psych, which I do, that you, whenever they do their yearly physical, you kind of see where they fall in the percentile, right? You don't want a kid that's in the lower percentile. They're gonna have low self-esteem, they're gonna feel depressed because they're the skinniest in the class and the smallest in the class. So sometimes, you might try to switch to a non-stimulant if they do well on it. All right. There are some meds that if they can't swallow, you can crush it. All right. And there are some that are extended release that come in little spanules, which you can crush. You make sure you can open it, the capsule, right? Ritalin LA, you can open the capsule. Adderall XR, you can open the capsule. And it comes in these little circular things. I think they're called spanules. And you can put them in ice cream, you can put them in yogurt. The downside is the kid has to eat it within an hour. Oh, I'm sorry, within 60 seconds, within a minute. Any longer, it doesn't work anymore. So the mom can't like open it up and tell Johnny, hey, Johnny, your breakfast is there, go eat it. If he waits, if he's watching cartoons and he waits too long, it's not going to work anymore. So literally, the mom has to open it right there and spoon feed the kid, or else it's not going to work. It's going to be a waste of medication. All right. Any questions with that? There's also patches. There's a new patch now for Adderall. I don't know the name of it because it's fairly new. And there's Daytrana, which is extended release of methylphenidate. All right. So that's for kids that don't want to swallow pills. I've never used patch in my personal experience because I feel like the kid could just peel it off anyway. And I've never had kids, and they can always just, if they can't swallow, we just use the spaniels. So I've never had, there was really no reason for me to do Daytrana. There was one time I had to do pre-authorization and the insurance denied it. So other than that, I never used it. All right. What's the difference between the two alpha-2 agonists, guanfacine and clonidine? There is a big difference between them. Which one is more selective? What do you think? Guanfacine or clonidine? Which one is more selective? Guanfacine is more selective. All right. Clonidine tends to be less selective, so it has more side effects. It can cause orthostatic hypotension. It can drop your pulse more. It can cause more sedation. But sometimes you want that, right? If a kid is hyperactive at night and they're having issues falling asleep, maybe clonidine might be the best option. If a kid is just having hyperactivity, maybe guanfacine might be the best option, right? Alpha-2 agonists tend to do better with impulsive and hyperactive behaviors, but they do work a little bit on inattention, but not as much as the stimulants. But unfortunately, a kid can't tolerate a stimulant, so you might have to use an alpha-2 agonist. Or you can use Qelbree or atomoxetine, all right? Guanfacine is metabolized by 3A4. So if someone wants to take chamomile tea, what's going to happen to the guanfacine levels? Is it going to go up or go down? What do you think?
Go up.
Very good. It's going to go up, right? Which, if you think the patient needs more guanfacine and they're refusing to go up on it, and they say, hey, I'm going to buy chamomile tea, why not? You can try it. But, just be careful. I mean, they might have more dry mouth and constipation, though. Okay, Strattera. So Strattera is norepinephrine reuptake inhibitor. Does it increase dopamine in the frontal lobe? Yes or no? And why? Even though it's a norepinephrine reuptake inhibitor, does it increase dopamine in the frontal lobe? Yes or no? What do you think?
Use the same pumps.
Very good. Yep. So you use the same norepinephrine reuptake pump. So technically, by giving someone an NRI, it will increase dopamine in the frontal lobe at the same time. All right. Because of, remember, volume neurotransmission that we talked about early on in the first lecture. So by giving someone an NRI, it's going to increase dopamine in early. Is it going to be as potent? Probably not. but you are giving them a little bit of dopamine also. All right. So that's the good thing. You might give them a little bit more. There might be better efficacy with NRIs when it comes to inattention than an alpha 2 agonist. And you can combine them. You can give them both. All right. A lot of these ADHD meds, you can kind of mix and match. Any questions? So I will ask you guys about the meds in general. So definitely know Vyvanse. There's like 36 different formulations, but they're all just broken down to isomers or methylphenidate solutions or amphetamine solutions. But I will emphasize the ones I want you to know. Definitely know about Concerta and know about its special release formulation. Definitely know about Vyvanse. Definitely know an immediate release like Adderall IR and know Ritalin IR. Know, what the duration is and how you would dose it. So there is an interaction with diet and one of these meds. What is it? What med here might be affected by specific diets? I'll give you a hint. So during COVID, a kid was very stable on Adderall, and all of a sudden, the medication stopped working. And the mom swears to me she was still giving the kid Adderall, but then it stopped working. What do you think what did the mom give the kid that made the medicine stop working? During COVID, that's the hint.
Vitamin C.
Very good, right? Vitamin C, because what's another name for vitamin C?
Uh,
What's the scientific name for it?
Ascorbic acid.
Very good. It's an acid, right? Ascorbic acid. So if you take too much vitamin C, which is more than about 500 milligrams a day, you're making your stomach pH go down, right? And that's going to increase the absorption. It's going to increase the excretion, I'm sorry, of the Adderall. So they're not going to get the same, effect of it. That's what happens in the ER. If someone takes a whole pill of their Adderall and they're trying to overdose to kill themselves, what does the ER do? They acidify their stomach. They give an IV pump and they acidify their stomach so they excrete it fast, right? Makes it shoot up. If someone really wants to stay on a very high, diet that's spicy, that makes their stomach more acidic, maybe switch them to a methylphenidate solution. There's no interaction, right? Assuming that it might work for them, but it might not. So that could be an option. All right. And the opposite happens too. If someone's given a proton pump inhibitor, right, or anything that lines the stomach to make the stomach more basic because they have acid reflux, it's going to prolong the effect of the stimulant also. So that's good to know. All right. So anything that affects the pH of the stomach with Adderall, make sure you rule that out before you start adjusting the medications. It could be as simple as that. All right. I mean, usually people aren't on proton pump inhibitors for a long time. They're not supposed to be, but if they are, then that's going to be a problem. Any questions? All right, to know this chart, have a basic understanding of the formulations. All right. This is the same thing. Again, if you look at the non-stimulants, I do mention Wellbutrin's on there. This is off-label though. So Wellbutrin, bupropion. If someone has comorbid depression and has symptoms of inattention and you don't want to give them an SSRI and stimulants at the same time, why not switch them to Wellbutrin and try it out? It might work. You might kill two birds with one stone. So I usually do that. Try to get them Wellbutrin and try to help the depression and their mood at the same time. All right. Modafinil almost got FDA indication actually for ADHD in children. What was the reason why it was pulled? Well, it wasn't followed through. Why did they give it indication? What happened with those patients? What do you think? Did they die instantly? They didn't die, but they developed a very bad skin rash, and the FDA was afraid that it was going to cause Steven Johnson's. So the fact that the manufacturer at the time of Provigil, modafinil, didn't want to do the REMS system. The REMS is the same thing as having to monitor it pretty regularly. They just didn't go for the indication. All right. Know that alpha 2 agonists that are FDA approved for ADHD are the ER releases. All right. So it will be Intuniv for guanfacine and 10x. No, 10x for guanfacine and Intuniv for clonidine. I think that was a mistake that they put in that chart. But just know that it's the extended release versions, all right? You can give IR, but there are some studies that show it does work, but if you want to be evidence-based, do the ER. All right, I have used IR anecdotally. I will tell you that some insurances have denied to pay for the ER, so I just put them on IR and the patient is doing just as fine. All right, and there are going to be anecdotal stuff with certain providers telling you that the same thing is the same. So you can try to get the ER approved, but if not, you can do IR and it works just as well. Any questions?
Is modafinil only used for narcolepsy, or is there
It's only
other
approved for that.
applications?
Yeah, it would be off label if you can use it for ADHD. Yeah. But just be aware if the kid develops a rash, I would probably be careful and stop it. Right. Side effects of treatment. All right. So obviously stimulants can cause anorexia, insomnia, stunted growth because it does suppress growth hormone. It can cause anxiety, right? It can cause psychosis and it can cause mania also. So in Europe, they actually don't use amphetamine solutions. Be careful because if you have a patient who's taking Adderall, sometimes you write them a note when they go to Europe because they'll confiscate it because they don't use amphetamines in Europe. They only use methylphenidate solutions. And the reason why that is because there's a lot of studies that show that amphetamines tend to be more psychomimetic than the methylphenidate solution. So what does that mean? That means that it actually increases psychosis more. And that makes sense. Well, what's the mechanism of action of Adderall, amphetamine based compared to methylphenidate? What does it act on? There's a pump, the VMAT pump, the vesicular monoamine transport, right? So amphetamines tend to be reuptake. So they go inside through the dopamine transport pump or the norepinephrine reuptake pump, right? It goes inside the cell and it's a false substrate for the VMAT pump. So what it does is eventually it starts binding to the VMAT pump and it reverses it actually. So what happens is that VMAT pump does the opposite. It starts spitting out dopamine. And once enough dopamine starts being spit out, they start getting pushed out. And you actually, not only do you stop the dopamine from being reuptake and staying in the clot, but actually increases production at the same time. So it increases dopamine and keeps what's there. So it's more potent. It can cause more psychosis. All right. A methylphenidate only works in the outside pumps, norepinephrine reuptake pump and the dopamine reuptake pump. But the amphetamine solution actually works on both the vesicular monoamine transfer pump, which is inside the cell, and the outside, right, which is norepinephrine and the dopamine transport pump. All right. So make sure you're aware of that. And the non-stimulants tend to be more benign, but their side effects are GI side effects. Usually nausea is a common side effect, headache, and fatigue. Right? How I usually deal with that is I tell them to take it with food, and I do a pretty slow titration. All right. I prefer Pulbri viloxazine more than atomoxetine because I feel like patients tend to tolerate it better and the titration tends to be better. It's once a day dosing as opposed to Strattera, which is usually recommended to be given BID dosing because if not, then patients can't tolerate it. There is a difference between the viloxazine and the atomoxetine. Viloxazine tends to work more in serotonin, so it's a 5-HT7 and a 5-HTC antagonist. So it does help with mood, it does help with anxiety. So in Europe, it's actually approved for anxiety disorders too. Even though in America, we don't use it for anxiety disorders, but if someone has ADHD and does complain of anxiety, before giving them an SSRI, maybe giving them viloxazine on top of the stimulant might be a better option because they get more bang for their buck with the stimulant and they also get a, symptom remission possibly from their anxiety because it does both. Does that make sense? Because it works in serotonin receptors. Atomoxetine is a very potent norepinephrine reuptake inhibitor, more so than viloxazine. So when you hit that receptor too hard, that reuptake pump too hard, it can cause more GI side effects, right? More fatigue, more headache. So when it comes to tolerability, viloxazine tends to be a little bit more tolerable. And if someone has comorbid anxiety, there is evidence that obviously because it's approved in Europe, that viloxazine might help with anxiety. All right. Any questions? No. This is just a breakdown of alpha-2 agonists. All right, look, like I mentioned, guanfacine is more selective. It's selected to the alpha-2A. Clonidine is the alpha-2A, 2B, and 2C. And that tends to work on all the other receptors that can cause orthostatic hypotension. So remember, if someone's on a pretty high dose of clonidine, like 0.4, 0.5, you have to taper them off. Because if you just stop, if the patient stops it prematurely, it can cause rebound hypertension. All right. So you should taper it. Guanfacine has more drug-drug interaction because it's a 3A4 substrate. Clonidine is metabolized by multiple CYP enzymes, so there's less interaction, but guanfacine tends to be more selective, but it has more pharmacokinetic interaction because it's a 3A4 medication. All right, does that make sense? All right, so we're talking about neurodevelopmental disorders right now too. That's part of the topic, but we don't really treat it per se. I usually treat autism indirectly, and they usually go to another clinic for that to treat with their social skills training. But we can give them some medications for their aggressive behaviors. And what are the two meds that are approved for aggression and autism? Do you guys know? Risperidone and Abilify. Risperidone and aripiprazole. All right, so those are two meds sometimes we use independent of psychosis, even if they don't have psychosis, but they have irritability and they have anger issues and they have autism spectrum disorder. Evidence-based would be aripiprazole or risperidone. I usually use aripiprazole first because it tends to be more benign and better tolerated. And of course, if that doesn't work, then I would use risperidone, right? Because risperidone can cause more extrapyramidal symptoms. It's a stronger D2 blocker, as opposed to Abilify, which is a what? What's its mechanism of action? Partial agonist, right? It's a prototypical partial agonist. All right, that's all she wrote. Any questions about, neurodevelopmental disorders or treatment of ADHD? ADHD is important, so a lot of the questions are going to be on ADHD because that's going to be something that you're going to have to treat a lot in psychiatry. And there's a lot of ADHD clinics popping up, so a lot of kids are getting treated for it. They come to you. You have to understand why they're coming to you, right? And why it might not be working, or why they might be having side effects.
I have a question, Professor Collada. So you said you've run a perinatal clinic too, right? Or worked with a perinatal clinic. How do you feel about ADHD management in pregnancy? Because we have a lot of providers
Yeah, it's
feel uncomfortable with ADHD medication in pregnancy.
I'm comfortable as much as the OBGYN is comfortable managing them. So in the past, I have continued it as long as the OBGYN was on board with it. But if they're not on board with it, I usually don't argue with them. Even though I try to say ADHD can affect other things besides school, right? More prone to accidents, car accidents. But, it's more of like the evidence is inconclusive. So if the OBGYN is not comfortable keeping them on it, I just, you take it off.
Okay.
Yeah. But I have in the past kept people in ADHD, depending on how severe the ADHD is, which they can't actually work and they can't put food on the table without it. And they're aware of the risks. And, I'm comfortable managing it, the OBGYN is comfortable managing it, and we're all on the same page. But if there's like any issues with being on it, I usually, I'll stop it, do it a caution, and then we'll restart it once they give birth. Yeah.
Is there anything that you would like? I know supplement's not the right word. Sorry, I've been up since 2 a.m.
No, it's
Um,
okay. So there's actually good
like if
evidence
you were,
that
you know what I mean? Like what you could use to help support those symptoms if those medications are not the safest choice.
Well,
Is there
besides the
another?
obvious, which is like using reminders, post-its, there is a lot of
Sure.
evidence now that the cerebellum is actually implicated in ADHD, which is great. And the reason why I say that is because we think about it more as a frontal lobe dysfunction, but the
Mhm.
cerebellum is also implicated in that. So the reason why I bring cerebellum is because balance actually helps with ADHD symptoms. So simple stuff like working on your balance, putting one shoe on one foot, within reason, when they can work their balance, has actually been shown to help with the symptoms. So
Hmm.
if someone's, obviously dangerous for a pregnant lady, but if they're able to work on their balance in little ways, that can also help. Yeah. But yeah, it's tough. I mean, when it comes to perinatal, there's a lot of data that's kind of inconclusive. So it really has to be shared decision making. I know it's a cop out. I would say that whatever the patient's comfortable with, I present them with the data. And as long as the OBGYN is comfortable with it or the nurse midwife is comfortable, we all kind of tie together. We communicate pretty frequently and we adjust it accordingly, right? Kind of like lithium, right? I mean, there's evidence now that shows that even in the first trimester, the risk of Epstein's anomaly is actually very low. That sometimes the risk of suicide is higher. That, of course, we have to adjust the lithium. We probably do weekly lithium levels because based on the trimester, your body tends to excrete lithium faster or slower. But other than that, we do keep them on lithium as long as the patient is able to stay on it and do blood work regularly. We don't have to talk about ADHD. If there's anything about last topics too, about anxiety, whatever, you can, because I mean, ADHD is, it's a small topic, but. So the final is cumulative, by the way. So I will recycle some questions, just reword them a little bit from the midterm that I thought you guys needed more work on, and I want you guys to really understand these concepts. But the final is cumulative. But there will be a lot of questions on antipsychotic meds or quote unquote D2 blockers because those are meds that are used across many different disorders that I want you to understand how to use them appropriately in depression as an adjunct, right? In schizophrenia, in bipolar, in aggression. So those are meds that, yeah, I might ask a lot of questions about those because those are used a lot. Like the point of me testing you guys because I want you to learn it and understand it. It's not, I'm not really trying to get you guys to fail the exam. I don't want you guys to fail it. I'm actually trying to make it a learning experience for you, the test. The test should be a learning exercise too, which is why I put hints on there. You guys didn't realize that already.
Is
If
it gonna
someone is,
be?
oh, yep.
No, you're fine. And it's a stupid question, but will you do like 50 questions on the new material and then 50 questions from the midterm, or like is it going to be more based on what we're doing now?
I'm not sure. It depends. I haven't made the final yet. So again, I'm making it from scratch.
Okay.
I guess depending on how much red wine I have that day, based on what it is. All right, good question. A patient is has a history of anorexia, not anorexia, of low appetite, history of insomnia, is put on their primary care doctor on mirtazapine, 30 milligrams, right? Their primary care doctor retired, now they're coming to you for an intake, and you realize they have untreated ADHD. And you're like, you know what? There's a medicine called clonidine I want to try. Would that be a good option? Yes or no? Why? I don't want to take Adderall. I'm afraid of Adderall. I don't want it to cut my appetite. I wasn't eating before. The mirtazapine's working great. I'd rather try a non-stimulant. Can I try mirtazapine? Can I try clonidine? Yes or no? And why not? Or why so? What's the mechanism of mirtazapine?
Here's something I found on ShareCare.
Shut up.
While it is not
Alexa.
understood exactly how
Shut up. Sorry, it's Big Brother. So remember, it's a alpha 2 antagonist, mirtazapine. So you'll be surprised how many times I see this interaction. Many doctors do this. They put them on mirtazapine for sleep, for insomnia, and then they're also on alpha 2 agonist at the same time. They cancel out. There's many, if you look it up online, even on Hippocrates, it'll say they cancel each other out. Is that a pharmacokinetic interaction or a pharmacodynamic interaction? Pharmacodynamic.
Pharmacodynamic.
You're blocking the receptor. Yeah, it's like giving someone propranolol and then they have an asthma attack and you give them a beta agonist at the same time. Right? It's not going to work because you're blocking the beta receptor and you're giving something at the same time. So you're blocking the alpha 2 receptor, which is a heteroreceptor at the norepinephrine neuron and also at the serotonin neuron. So you're an alpha 2 antagonist, mirtazapine, and you give them an alpha 2 agonist. They counteract, they cancel out. They're both not going to work. Right? So you would probably say, unfortunately, no, clonidine might not work, but what about Strattera? What about viloxazine, right? Norepinephrine reuptake inhibitor. Or what about stopping your mirtazapine and just going on one med right now, viloxazine, right? Because you're increasing serotonin and norepinephrine at the same time for both. And obviously you would explain to the patient why, right? And you might get both effects from the same medication. See how like understanding the nuances of each med can help with polypharmacy and get your patient kind of, trust you a little bit better? Because they know you, because it's very easy to just keep adding meds, right? That's what happens. That's why polypharmacy is so rampant in psychiatry. People go to different providers. One provider is like, well, I don't want to stop this med because it might be working. Let's add something. And then they fire you for whatever reason. They go to another provider. Well, Richard added this and they were on this. Let me not remove it. Maybe it's working for them. Let me add this to help with the other symptoms. And then they start collecting meds. So, I mean, sometimes less is more, and there could be pharmacodynamic interactions, right? Or pharmacokinetic. Someone could be on like 5 meds and they're taking carbamazepine from their neurologist for, trigeminal neuralgia, right? And none of their meds are working. It's easy for me to add more meds, or I can just say, well, maybe your neurologist can switch from carbamazepine to something else, right? It's a very strong inducer. If that truly is the only med that works for you, then maybe I might have to do some extra digging and do meds that aren't metabolized as much. Like even though it would be impossible, carbamazepine is a pan inducer. It induces every CYP enzyme almost. But then you don't get caught up in keeping adding things. That's a pet peeve of mine, polypharmacy for no reason, right? There is such thing as rational polypharmacy where you're giving someone I'm giving someone clonidine and Adderall. It's polypharmacy, but it's rational because I know I'm getting a buy one, 1 + 1 = 5 effect, right? It's synergistic. They're helping each other, complement each other.
Sorry, I didn't hear the other medication you said you would give. You said Strattera and which other
Strattera or viloxazine, they're both norepinephrine reuptake inhibitors, right? And with viloxazine, since there is evidence that helps with mood and anxiety, maybe stopping the mirtazapine if the patient trusts you enough and switching to that one med instead of taking 2 meds might be an option. which I've done in the past. I've done that with patients. That's why genetic testing, I'm not really a big advocate for it because I know genetic testing is marketed a lot and some places will market it. Well, we do genetic testing, this is what's special about my clinic. But in reality, there's so many different ways that meds could be altered when their metabolism that at the end of the day, genetic testing is probably the best option. You're getting the end result and the net effect of everything, right? If you do pharmacogenetic testing, sure, it might tell me you're a fast metabolizer or a slow metabolizer, but it's not going to tell me that you're drinking chamomile tea every day, right? It's not going to tell me that you're smoking cigarettes every day. It's not going to tell me that all these other interactions. That at the end of the day, it's probably better just to do the net effect. Just do a level and see. Then you can ask, well, I'm giving you 3 milligrams of risperidone. It's showing me a level that's below that, right? It's 5 instead of 21. They'll say, well, I did miss a few doses, or I am taking it every day. I don't know what's going on. Let's go over your other things that you're taking. Are you taking any other stuff, right? Well, my doctor did put me on omeprazole for my acid reflux. Well, it's an inducer, right? There you go. That's why your risperidone is not the way. You know what? It's like little things can happen, and sometimes patients don't even remember or know the meds they're taking, right? I had one time a patient came in and I said, "Bring all your meds with me." They usually bring it in a plastic bag. Let's go over your meds. Oh, they were taking um, bupropion for smoking cessation, which is branded, which is called what? What's the branded medication for smoking cessation? That's Wellbutrin, bupropion. Oh my God, I can't think.
Wellbutrin?
Zyban.
The Zyban,
Yeah.
sorry.
Like, well, I'm taking Zyban and someone else is prescribing me Wellbutrin. Did you know that's the same medication? One bottle says Zyban on it and one says it's the same med. You're taking like double the dose, right? Because people don't know that. Let's say Tylenol, acetaminophen. There's acetaminophen and everything. That's why the dose, it's easy for people to get toxicity because it's found in so many different other meds that people take more of it. So always ask. Especially if they go on a different specialist. Like gabapentin. How many gabapentin prescriptions is the patient gonna get? I get gabapentin from my neurologist, I get it from my primary care doctor, and I want you to give it to me. Right? They're on like 4,000 milligrams a day already. Right? It's not controlled, so you can't really find it. Like how many prescriptions of gabapentin is the guy gonna get?
Hmm.
I've actually been using gabapentin for outpatient alcohol detox, and it works really well.
Yeah, it does. I like gabapentin. They got sued, that company, gabapentin. They got
Oh
sued
no,
because the reps were using it. We're going to doctors and other providers and saying, oh, gabapentin can help with this. It was like a panacea. It helps with everything. Anxiety, alcohol use disorder, mood disorders. They've studied it in bipolar. It didn't help. Because they assumed that, well, Depakote works. What about gabapentin? It increases GABA. Depakote increases GABA. Let's try it. Didn't work. It does have evidence in GAD though, general anxiety disorder. It does help with that. And there's a version of it that's used in Europe called Lyrica, right? Which we only use for pain here. It's an alpha 2 delta ligand medication also that works on calcium channels. Similar. It's funny. One is controlled. Lyrica is controlled, but gabapentin is not controlled. You can prescribe as much as you want. There's some states that are talking about controlling it though, because it is rampant in some.
I feel like it's going to get controlled soon because I think people misuse it.
Yeah. So hoard all the gabapentin that you can now, so when it becomes controlled, you can sell it. Pay off your student loans. No, I'm just kidding.
why is it controlled when gabapentin isn't? Is there a reason?
Because there is some studies that show that people sniff it and it gives a synergistic effect with opioid use disorder. Well, people use opioids and they sniff gabapentin and it increases the euphoria. Yeah.
Okay, yeah, I was always wondering if it was just like a weird idiosyncrasy of the law. Like, you know how like with the migraine medicines,
Yeah.
Fioricet is uncontrolled, but the one with I forget, the one with aspirin is
Yeah.
controlled, but the one with Tylenol is uncontrolled. And it just has to do with the ratio of barbiturate to
Yeah.
um, yeah, it's a weird one.
That is a good question. So talking about like ADHD meds, they're working on triple reuptake inhibitors right now. So there's actually like some studies that they're trying to work on because technically increasing dopamine, norepinephrine, serotonin in theory can help with ADHD and mood disorders. So there is a high comorbidity with ADHD and mood disorders. So people are trying to find triple reuptake inhibitors, right? The only problem is, I don't know how they determine this, but if it hits dopamine too fast, too strongly, it could become addictive, and the FDA is going to brand it as a controlled substance, right? They're going to schedule it. But if it doesn't hit dopamine that strongly, kind of like Wellbutrin, there's like a threshold. I don't know the exact threshold in which it's not going to be controlled. So it's interesting. So the ratio actually is if you make it more serotonin than dopamine, because what happens if you increase serotonin too much, it causes GI side effects, right? So people try to abuse it, they're gonna feel like shit, and they're not gonna take any more of it, right? So that's kind of like the way of stopping that. But then you also have to give them enough dopamine, which is actually gonna help them with their attention. So there's like a balancing act there.
This isn't anything that you've taught us, but I was watching one of your videos and you were talking about a new drug called Ovelity.
Auvelity, yeah, it's not new anymore actually. I've been prescribing it. It's been out for a couple of months. Yeah.
What can you just discuss it? I'm just
Yeah, of
curious.
course. Sure. Auvelity is a medicine that we use now for depression. I don't know if it's approved for treatment-resistant depression, but we do use it for depression. You can get it as first line, and it's a combination of Wellbutrin, bupropion, and dextromethorphan, which is what? You know the mechanism of it? It's an NMDA antagonist. All right? An NMDA antagonist. Very similar to ketamine, right? Why is ketamine so effective? It's an NMDA antagonist. So, I'm going to simplify it. I know the videos are complicated online, but I've been told that the way I explain it tends to be better. So your glutamate receptors have two receptors on it, right? There's two main receptors that are responsible for it. NMDA, and there's oh my God, I'm blanking out. God. Oh my God, I'm blanking out. But by blocking NMDA receptors, that other receptor I can't remember for some reason, causes NMDA to bind to it. So causes glutamate to bind to it. When you block NMDA receptors, glutamate can bind to NMDA. It binds to these other receptors that I can't think of right now. But when NMDA binds to receptors, the cascade effect that causes neurogenesis and causes people to have more formations. So when people have depression, what happens is your neurons tend to kind of wither away and they die and the connections kind of go away. Right? So no matter how much serotonin or epinephrine dopamine you increase, if those connections are not there, it's just not going to work, right? So the key is sometimes you have to give people ketamine treatments to get those receptors to kind of regrow again, and then they'll respond better to their antidepressants. I think because I worked in ketamine for about a year, and the reason why I left that organization, which I'm not going to say because they're blowing up right now, is that I still saw patients that kept coming back for the ketamine treatment, right? And the way we marketed that treatment was that, well, you can get off your antidepressants if you just do ketamine, almost like it was a cure. But it wasn't a cure. People would still go to ketamine treatment once a month. What's the difference about getting ketamine once a month, which can cause hypertension, possibly have euphoric effect, cause substance abuse issues, possibly cause psychosis or mania, or take, Zoloft every day, right? I get it. The side effects are different, but there's those long-term data to show that NMDA antagonists like ketamine are safe for you, right? It's still kind of, we're trying to figure that out now. And there's no guidelines to say, how long do you do it for, right? Is it 5 years? Is it 2 months? Is it 6 months? No one really knows. So Auvelity is a pill form of that. And what the Wellbutrin does is it's a pharmacokinetic interaction. So dextromethorphan usually has a half-life of about 3 or 4 hours, right? So people can drink cough syrup and it does help with the depression, but then it goes away. But the problem is sometimes it can get converted to something called dextrorphan. Dextrorphan is a very strong NMDA antagonist, which can cause euphoria, and people can also they put it in they put that in a drink. It's called scissor. Any of you guys listen to rap music? It's called scissor. So they are drinking the scissor, and it's cough syrup that they drink with liquor, and they get the NMDA antagonism from the cough syrup, which gets converted to dextrorphan, which gives them a high, right? By giving them an inhibitor like Wellbutrin, it actually blocks that conversion because you need induction to do that, right? So if they took let's say they took an inducer like carbamazepine, right? Hopefully no kids are watching this. Don't do this at home. They do an inducer, it will actually convert that faster to dextrorphan, right? So they actually get more of it. So by giving them an inhibitor, you stop that conversion, and it makes it more of an antidepressant, and they get more of effect and it's prolonged. So it's actually safer as long as the Wellbutrin there. And plus, probably the dopamine and norepinephrine reuptake also contributes to some of that. So it does work. I have used it with good effect with patients. But sometimes patients are very sensitive to the Wellbutrin. It gives them the jitters. So if they can't tolerate the jitters, then it might not be good option, or it might sometimes cause increased anxiety. But for someone who's had sexual dysfunction, who's had weight gain or SSRIs, Auvelity might be a good option for them. And that's what happened. I bridged them from an SSRI to Auvelity, and they're doing pretty well.
And it's also like if people are treatment resistant to like SSRIs and
It's not
SNRIs.
approved for that, and I don't want to answer. I don't want to give you the wrong answer because I have to read the studies to say the rep comes to my office and mention that it's been studied, but I don't trust the reps because sometimes they'll say anything just to get you to prescribe it. And I
So
want to
what
read the
would
studies
make you
myself.
order it for someone then? Prescribe it? Just the weight gain, the sexual dysfunction.
Yeah, someone who's felt flat on SSRIs who couldn't
Okay.
tolerate it. You know, obviously it's only adults because it's only approved for 18 and older. So yeah, I've been prescribing it. It's a pretty good med. Yeah. The thing about depression is if you look at the STAR*D trials, right? When they were giving those meds, was it 30% had full remission, 30% had partial remission, had a response, and then another 30% had no response. So the treatment is not that great, right? It's unmet need. That's why there's so many people, you know, trying to jump on the bandwagon of TMS, um, ECT, right? Ketamine treatments, because there's a lot of people that they don't do very well in our treatments. But the problem is you want to make sure you give them a good dose of our standardized treatment first before you jump the gun and say you should go to ECT right away, right? Or go to, because again, there's risks there. So I always want to do a good history. Okay, you said you tried Zoloft, you tried Prozac. Can you please tell me how long you took it for and how did you take it, right? Well, I took Zoloft for about a week and then I had really bad diarrhea. Okay, how many times have that? One time. Okay, can you tell me about that one time? Well, you know what? To think about it, we ordered Chinese food from this place and it gave me bad diarrhea. Is it possible that was from the Chinese food place? Why don't we try Zoloft again? Right? Because I really want to disqualify that those meds actually don't work for a patient before I actually put them on stronger treatments that are not as studied, right? Like Ovaltine, which so far seems great. But it's a new medication, so the studies have not been shown, right? We have 20 years of data on SSRIs. We don't have that with Auvelity yet. So I don't know 20 years down, I don't know, is your penis going to fall off in 20 years? I don't know, right? Maybe. Because I mean, SSRIs cause sexual side effects, but I don't know, right? I'm just making a joke, but there's less data that I feel more comfortable with the establishment. Like with clozapine, when I talked about schizophrenia. Sure, people praise clozapine. Clozapine is a great medication, but do I really want to put patients on clozapine prematurely if they haven't had adequate trials on risperidone or Abilify? Right? Because it's a med that might cause weight gain and they have to do blood work. And there's a risk of agranulocytosis and constipation. So really make sure that they try the studied meds first before you jump the gun and go for the stronger meds. All right. But at the same time, don't withhold good treatment because you think that it's too toxic for them, right? Like lithium. It's under prescribed, right? Which is why I'm very big advocate for you guys knowing lithium. I think it's an art of prescribing that people are forgetting because a lot of the farm industries are not really are going against it, right? Lithium is an old medication. Why are you giving them old meds? It's the only medication that showed data to help with suicidality. Can you show me how your new med is going to help with that, right? Even Auvelity hasn't been shown. Lithium has shown neuroprotective factors, which is why there's a brand of lithium that's combined with another formula of something. I can't think of it. It's another supplement that's actually being studied for Alzheimer's dementia. Lithium for Alzheimer's dementia, branded version of it, which they're also studying for um, bipolar depression or bipolar. Sorry. All right, so don't get too infatuated with new medications. Sometimes the old meds are just as good. You know, like MAOIs, monoamine oxidase. You should, I prescribe it to a few patients. I still do. And you should know how to monitor it and how to prescribe it, right? All these old meds, there's still a time and a place for it. Like Haldol. I know I asked a question on Haldol. Some of you guys probably saw it. Haldol, old med. People are telling me it's a dangerous med. That's probably not the answer. It could be the answer, right? What if a patient, there was a patient, I told you guys about the Haldol. Well, the mom was a nurse and couldn't afford Invega Sustenna, right? So she had to pay out of pocket for it. There's no way that the insurance could pay for the Invega, which is like $3,000 a month. The Haldol was 150. So from of course she knew the risks, but he was only going to be on the Haldol injection for a couple of months till he turned 18. So she agreed, she paid for it, and it was fine. I have a student from I teach for you guys are Stony Brook, right? Yeah, you guys are Stony Brook. Sorry, I don't want to talk crap about other organizations, but I teach for Pace also, and I had a student was like, "Why are you talking about lithium?" They were so bold about it. Like my preceptor is a psychiatrist, and he's like, he hates lithium. He never prescribes lithium. I'm like, I'm sorry, you should find a new preceptor. Like in my it doesn't matter if they're psychiatrists, they're an NP. If they're very like never do this, never do that, to me that's a red flag, right? Because there's so many patients that do so well in lithium that once you're jaded and you're teaching us, and I was pissed off that they were teaching the student to stay away from it. Yes, it's a dangerous medication. Many meds are dangerous, but for you to withhold it and teach a student that it's dangerous and bad, is malpractice. And you're withholding very good treatment for other patients. So I told her, I was like, maybe next semester you should find yourself a new preceptor. You'll rarely ever see me never do that, right? Because there's a time and a place for something. As long as you understand the mechanism of the meds and the interactions, it could be safe, right? You can give a screwdriver to a 3-year-old and they could do, or a scissor to a 3-year-old, they could do a lot of damage with it. All right. It's not the tool, it's the person. I know the new fad now is MDMA psychedelics, right? Magic mushrooms, MDMA. We'll see. I have patients are asking me about microdosing now. How do you feel about microdosing? Meanwhile, they won't take meds. I don't want to take Prozac. Why am I taking meds every day? I read something about microdosing. I take a certain amount of mushrooms, magic mushrooms every day. All right, you're willing to take that, but you're afraid of taking Prozac every day, right? It's crazy. But you got to work with the patient, right?
Mhm.
Why do you feel safe
Well,
with that?
mhm. Is the psilocybin studies are kind of similar to the ketamine studies for treatment-resistant depression? Like, is the mechanism the same? Or
Yeah, 5-HT2A agonism, right, which is the main mechanism, it's a serotonergic medication, has shown to help down regulate GABA and increase all the other neurotransmitters and also increase neural growth factors. So yes, in a way, it does help with connections, but the problem is, how do you know that some connections being formed are going to be good, right? Like you're forming connections, but how do you know like a connection connecting one part of the brain to another part is actually going to be a good thing? I don't know.
Mhm.
And again, it's combined with psychedelic assisted psychotherapy at the same time, right? No one's ever said just taking mushrooms by itself is going to help you with depression. There also has to be a person there guiding you through the process and talking through it with you, right? What if that person is not trained in it accordingly? And then these connections are being formed and the person is saying the wrong thing, or you have trauma and then they say the wrong thing and you re-traumatize the person. Now this new connection is being formed and now their symptoms are worse. It's like this, there's just so much room for error right now that I think that more studies need to be done. And the problem is people are desperate, and I get it. There's people that are suffering with depression for such a long time, but I think there's big companies out there that are kind of taking advantage of that fact and trying to make a lot of money as fast as possible. So they're trying to fast track a lot of stuff that we don't know much about. I'm not against it, but I think we should slow things down a little bit because patients are desperate. And when people are desperate, they're more eager to spend their money and they might waste their money.
Meeting clinics, do they check, like, actually check to see if you've done 2 courses of antidepressants, or do they just care that you have the money to pay for the treatment?
So they're supposed to, because when I worked at the ketamine clinic, I would always say, before you start treatment, I want to speak to your other provider, and I would have to do a 30-minute consultation. But if they didn't do that, I wouldn't. But there was a patient of mine actually. So this is a very tragic case. So she was 16, history of anorexia nervosa, history of depression, history of PTSD. She was being abused by her uncle for years, complex PTSD when she was younger, and the mom was very invalidating. So it happened in Ecuador, and then the mom moved her away from Ecuador, and now she lives in Queens. And mom was like, let's not talk about this anymore. You're not near him anymore. It never happened. And it was invalidating for the kid. And the kid started self-harming, started getting involved with the wrong type of kid, started using substances, and was coming to me for depression. And I told the mom, I said, okay, oh, chronic history of suicide. She had like 3 suicide attempts, sorry, before she came to me. So she was doing okay on the antidepressants, but still had chronic suicidal thoughts. I told the mom, look, why don't we try adding lithium, low dose, right, to augment the SSRI? But you have to hold the bottle and give it to her so that she doesn't overdose on the whole pill. Mom started reading up about the lithium online, said, oh, lithium's dangerous. I don't know about lithium. I don't know if I want to put my daughter. And for some reason, an ad popped up for ketamine treatment for her daughter, right? Do ketamine, it'll make depression go away. Get off your medications, right? So she did a consultation with the psychiatrist there. And they're like, okay, no problem. We'll give her, I think it was like 6 treatments, and she paid $6,000. This is a mom that works at a nail salon, doesn't have the means for it, but took her savings and paid $6,000 to the psychiatrist. And I was like, wait a second, this is a bad idea. I was like, because I wasn't sure if bipolarity was there already. She had some hints of probably hypomania, some days of like not sleeping, impulsive behaviors, but I was ruling that out, so I wasn't sure. especially since she was 16. If it wasn't gonna come out, it would be coming out now, right? So I was very hesitant, and I was very close to augmenting with an atypical or maybe stopping the SSRI, right? That's why I also wanted to add lithium because I wasn't sure if there was bipolarity there or it was just suicidality from the depression, right? Trying to kill two birds with one stone. Mom missed the last appointment. The second appointment, mom calls my phone. I'm like, what's going on? She's like, no, I need your help. I need your help. We did the treatment. And now she's worse. Now she said that it brought up her trauma, and she was reminded more strongly about what my brother did to her. Now she just wants to kill herself. Now she has no hope, and she doesn't want to take medication anymore, and she just wants to kill herself, right? So we sent her to the ER. The ER was like, you know what? I think she's willing to go back to your clinic. They didn't admit her. There was a safety plan. I was seeing her more normally. Finally, the symptoms got better, but it was like 2 weeks on the ketamine for the first ketamine treatment. And guess what? The mom had signed a form that said that there was no refunds. So she paid for the 6,000 up front. And the doctor was like, all right, we're not going to do the other treatments because of this, but we're not going to give you a refund. Crazy. I called the office complaining, and I was like, let me talk to that doctor. The front desk wouldn't let me talk to the doctor. And she lost her money. Yeah, $6,000. And they never called me. I was like, well, how come they never called me to consult with me, knowing that I was treating her for years to say, was she a good candidate for ketamine? Oh, we tried calling you, but you never answered. I don't have any records of you calling me. Oh, you must have called the clinic. The front desk didn't tell you. I'm like, when did you call? Who did you speak to? Of course, they couldn't give me a name.
Yeah, they're lucky they didn't get sued. I feel like I would be happy to give a $6,000 refund rather than have
You
to deal with
know,
a malpractice suit.
I know. They took advantage of the fact that the mom was kind of like, she wasn't the best educated. She didn't really want, I don't think she could hire an attorney. It was many things. They took advantage. You know, Unfortunately, they actually moved to Arizona, so they're no longer my patient. So I feel like mom wanted a new change of scenery because after that treatment, she didn't do so well. And mom thought it was more of like her environment of hanging out with the wrong kids. So she was like, let's move to Arizona and see. We did connect them with another therapist and psychiatrist there, but I haven't heard from her. I don't know how she's doing. But again, that's when treatment can go wrong, right? I mean, I don't know if the psychiatrist's intentions were good. I'm hoping it was that he actually hoped that they would help the girl. But again, he didn't do his due diligence and ask me first, right? Or maybe it was money driven. I'm not really sure. I don't know. And patients will try that, right? All you can say, like they'll say, well, I want to get a second opinion because I read that there's some psychiatrists giving ketamine or psychedelics. All right, you're entitled to your second opinion. I'll document that though. Patient wants to go to a different provider, wants to inquire about ketamine treatment, risks and benefits of ketamine treatment were explored with the patient. Is aware that the next provider should call clinic to discuss. You know, Patients can tell them, I don't want you to talk to Richard, right? But then that's on them now. I did consult them and they said, hey, that's on you. I told you that you should talk to me first. If you want to go through with it and you have side effects, that's on the other clinic now that's giving the treatment without consulting with me, right? I did my due diligence. Good questions though. We'll go to 1:30. So if you guys have any more questions or like I want this to be interactive because this is how you learn and it's such a big topic too. So any way I can make it more practical for you or give you examples.
Right, this is a stupid question,
I
but
give you a stupid answer.
carb carbamazepine is a pan inducer. So
Correct.
that means that it induces like the end
Majority of this.
munch of the
Right.
enzymes.
Yeah. The ones
Okay.
that are significant for psychiatry, like 3, 4,
Okay.
2C9, 2C19. Yeah. So 2D6 is not inducible in vivo, but it's been shown to be inducible in vitro. So there might be some people that do lectures and say, yes, it will induce 2D6. And there might be some people that say, no, it doesn't induce 2D6. Just be aware of that. Anecdotally, I've had patients on 2D6 meds and they took carbamazepine and the meds stopped working. I will tell you anecdotally, I've seen it, right? But if you read about it, there will be some literature that says 2D6 is not inducible, only in vitro, I guess in a test tube, but not in vivo. But I want to be as accurate as possible. And there are also some, just be aware though, that sometimes it's very hard to find out what CYP enzymes actually metabolize specific meds. So if you go on different, like if you go on stalls, on I prescribe or on prescribe and stalls, and you go on Hippocrates, some might say, 3A4, 2D6 for Abilify. Some might say it's just 2D6. Some might say it's, majority 3A4. So there is a little bit of discrepancy there. So just be aware of that. But there are some things that we understand, right? Like clozapine is majority 1A2. So you do know that if 1A2 is affected, clozapine levels are going to be affected. Whether 60% is 1A2 in some books or 80% is 1A2, just be aware if you induce 1A2, clozapine will stop working. If you inhibit 1A2, people are at risk of you know, developing side effects.
For autism, how often are you using pharmacotherapy? Like always, sometimes?
That's a tough question. It depends on what symptoms of autism they're presenting with. If it's more self-harm or aggression to other people, right? Low distress tolerance, then I would use it sooner at the lowest dose possible, right? Because I still want them to be able to kind of like, function. I don't want to oversedate them.
Mm-hmm.
If it's more like
And
Asperger's, high functioning, then possibly, I might not need to.
and how young can you start? If you got a 3-year-old or who's like biting the kids in
I
pre-K?
believe I believe as young as 4 for Risperdal.
Okay, yeah. Mm-hmm.
But 4 years old, I tend not to medicate kids, as much as possible. And when it comes to ADHD, usually 6 and older is when you really start the medications. That's usually from the guidelines. 4 to 5, you can, depending how disruptive they are. If the parents can't handle them, you might. But usually it's more, behavioral interventions or psychotherapy with them or play therapy to help. But you do see, alpha 2 agonists use a lot for them. Because, when they're growing, you want them to get a certain amount of calories in. So you don't really want to cut their appetite. So when it comes to child psychiatry, we call something called externalizing behaviors, right? Externalizing behavior are like the behaviors that you see overtly, right? And sometimes, boys might show that more and they might get diagnosed with ADHD a little bit more, right? Because boys tend to be more hyperactive and girls tend to be more inattentive. So they're kind of like in the back and they're not really causing a disruption, so people don't pick up on it, right? I've also had with kids where epilepsy is there and they might be having seizures and it gets misdiagnosed as ADHD. So if a patient is like spacing out or staring out and it happens sporadically, intermittently, I would probably send them to neurologist first to rule out seizure disorder, right? It could be an absent seizure, which happens a lot with kids. Because you give them psychotropic medication, which lowers the seizure threshold and actually makes it worse. So if you give someone a medication that's psychotropic and then their ADHD quote unquote gets worse, I would probably assume that you're lower than seizure threshold, send them to a neurologist and rule it out. Other externalizing behaviors are oppositional defiant, conduct disorder. I know this isn't a diagnosing class, but you're going to see that a lot of these kind of interlap, right? Kids who have ADHD will sometimes be, oppositional, right? Sometimes they will have behavioral issues. I've had a parent say, "Oh, can you please add a diagnosis of oppositional defiant disorder to their ADHD?" I said, "Yes, I can, but what is that going to do for your patient, right? Remember, that carries on the chart forever. So do you really want your kid to have a diagnosis of ADHD with oppositional defiant disorder? I know it's only a diagnosis, but that could be stigmatized. So we can still treat the symptoms without putting that label there. I mean, it's up to you how you want to practice, but that's how I practice. I try not to give that label with kids because it does make sense too. If someone has untreated ADHD, right, the teachers are going to yell at them all the time, and the other kids are going to say, "This kid is never paying attention. They're a bad kid," right? Everyone starts labeling them as a bad kid. Of course, they're going to act what people. If people keep saying I'm bad as a kid, I'm going to be bad, right? Let me give you a reason to call me a bad kid. I'll start acting out, right? That could be a reason why they're very highly comorbid. So usually you do want, so sometimes parents are hesitant about starting meds right away I'll go over the risk and benefits, right? The risks are it could be stigmatizing. They'll have difficulty making friends, right? Teachers are gonna yell at them more. They're gonna get embarrassed. They're gonna have low self-esteem. They might go through high school and start self-medicating, right? Early childhood pregnancy, right? When they start driving, they might have higher risk of accidents, right? So the earlier that you treat it, the better their outcomes are. And of course, we'll always because they're always afraid of abuse potential, right? But there's also abuse potential of people who are self-medicating. So it's always harm reduction. Let's put them on a low dose that's controlled, and then we go from there. Sometimes your frontal lobe does get better. So remember, males, their frontal lobe usually develops what, age 25, right? Or sometimes late 20s. Females tend to go, early teens to early 20s. So sometimes with males, it takes a little bit longer for for things to set in place, but sometimes they can get off the medication or lower the dose at least. And also depends on what jobs they're going to take, right? If someone's going to work, I don't know, sanitation or work like a job that's always the same routine, going the same route all the time, doing the same stuff over again. There's no breaking in. You're not learning new skills all the time. You're not having to attend meetings. You might not need ADHD medication, right? But if you're a lawyer, you always have to read about law. You're a nurse practitioner, RN. You always have to learn new things. ADHD meds might be a given for you all the time. It depends. I do have some kids that in the summer, the parents insist they want a drug holiday for the summer. I present the data that it could still be dangerous for accidents, but parents don't want them on meds for the summer. So I stopped the ADHD meds. They don't down ADHD meds July and August. They've been okay, so.
Would that make them less effective when they go back on them, or it
No,
doesn't
no,
matter? Okay.
no, not really. That's been disproven. Tachyphylaxis with ADHD meds has been disproven. People will still, they might outgrow it, right? They might, based on weight and height, they might need a higher dose. But being on the same dose, I've had patients on the same dose of stimulants for a long time, and they're okay.
Someone like retires from their job, is that it then? You just say forget it for your Adderall prescription?
I've never treated anyone older than 50 with stimulants, but I do watch lectures about it. So I do know that in geriatrics that there's an argument that you should, I guess as long as their EKGs are fine and their primary care doctor is okay with them being on stimulants, then it's fine.
Mhm.
Yeah. Well, listen, just because you're 65 doesn't mean you can't learn new skills.
Yeah.
People are starting, no one's retired. Everyone's like starting new careers nowadays. Right?
Yeah.
As long as they're medically able, then yes, they can still be on it. It's funny, in psych, there's some meds that were too, what's the word? We're too frugal about prescribing, so like stimulants, right? So a lot of times patients should be under prescribed stimulants because everyone's afraid of abuse potential and the euphoric effect. But sometimes, so one of my mentors was actually an ADHD specialist. So the way he taught me and the way I practice and the way I teach people is you want to push up the stimulant to the point that they have side effects, right? So I taught about Adderall IR. It's up to you. I mean, it's controversial, but this is the way I practice and I have good effects with it. And patients will tell me, wow, I never would have thought that this higher dose would have helped me so much more in school and changed my life, but it has. Enough patients have told me that I do this practice now. I push it up until they have issues with sleep or they have issues with appetite or they can't tolerate it because of their anxiety. If that happens, we go down again. I don't give them a prescription for a month. Obviously, I do that titration after maybe 5 days or 3 days or 7 days, but I see them pretty frequently. I keep raising it. I'm going to give you 3 days of Adderall 10, right? I'm going to give you 3 days of Adderall 40. 40, okay. 50 was too high. What happened? I couldn't sleep and I felt too anxious. All right, let's go back down. But I'm happy with this dose. Because if I would have kept them on the 20, sure, I'm better than I was before, but I'm not maximizing the potential. They still have some breakthrough in attention, but they're afraid to ask for a higher dose because they think I'm going to judge them and think they're med seeker. See what I mean? So I just say, let's try to maximize it to what gets you the best, and we'll cut down once you have a side effect. Right? So that's how you do it. Give doses for like a week at a time or a couple days at a time and increase it until they can't tolerate it. Then you go back down. Can you give stimulants to a patient who has schizophrenia or bipolar disorder? Controversial topic, but what do you think? Yes or no? Because they could be comorbid. Someone could have both technically. Would you give a stimulant to a patient who has schizophrenia? What do you think the studies say? It's been studied.
I mean, maybe if you're trying to improve negative symptoms, but I would imagine it, otherwise do the opposite of the dopamine blockade.
Yeah, so yes, you can. The answer is yes. And the only time I do it is if a patient I know is on long-acting injectable, or I know that they're diligent with taking their meds. The problem is if they're on a medicine that has a short half-life and they miss a dose, let's say like olanzapine. There is an injectable olanzapine, but it's very hard to offer because it causes something called post-injection delirium syndrome, which, it could be dangerous. So I don't really offer that injection. But let's say if they miss like 2 days of their olanzapine and they're still taking the Adderall, you have a naked mesolimbic area now that can be hit with dopamine. It can cause psychosis. But if they're on
Mhm.
like injectable, like Abilify or Invega Sustenna, sure, right? It's just it's a balance. Give them just enough dopamine in the frontal lobe and so you want to be able to innervate the D1 receptors in the frontal dopamine 1 receptors and not innervate the D2 receptors in the mesolimbic area, right? There's different types of dopamine receptors. So you want to give just enough so the dopamine D1 receptors in the frontal lobe are helping you focus and concentrate, but not enough that the dopamine is binding to D2 receptors in the mesolimbic area. But assuming you have a D2 antagonist there or D2 partial agonist, it'll keep it safer, right?
Mhm. Do you encounter a lot of like unmasked psychosis by people who are just starting stimulants for the first time?
I have,
I
yeah, I
mean,
have. Yeah.
like I've seen people like totally spawn on crystal meth, and it's like the same as someone who's having an acute psychotic episode. So I wonder,
Oh, this
you know,
is
I just
actually this is great. This is a great conversation about pharmacokinetics now, pharmacodynamics, all right? Someone's high in crystal meth, abusing crystal meth, comes to you psychotic, right? And you're in the CPAP. Do you give them a dopamine blocker to calm them down? Yes or no? Why and why not?
mm, mm,
What do you think the answer is?
mm. I think the answer is
No.
no, and I would give them a benzo instead.
Okay, but why
Um,
though? I know you working in substance, you probably know the answer is no, and people will tell you give a benzo instead. But why is that practice? This is a good exercise in breaking it down and understanding medication with neuroanatomy. Why do you think, Rob? What's happening if you give someone crystal meth, right? It's an amphetamine, it's hitting your dopamine receptors, right? It's giving you euphoric effect. What happens to those postsynaptic dopamine receptors over time that's getting hit with dopamine? Is it going to upregulate or downregulate?
They're going to downregulate.
Very good. To downregulate and become less sensitive, right? Now you have a downregulated, desensitized postsynaptic receptor, and now you're going to give someone a dopamine blocker. You're going to shut off all that dopamine, right? You're gonna put them into dystonia really bad, and you're going to turn them into a statue, right? Because now you have a dopamine blocker, and whatever's there is downregulated and not sensitive is going to be blocked with dopamine receptors. So what you need to do is give them a benzo to get their body to adjust to not being on that amphetamine anymore. Right, so that's the answer because you're gonna shut their body down. You have down-regulated and non-sensitive receptors. Now you're gonna block what receptors are left there to protect itself with a D2 antagonist, right? So that's why you don't do it unless you don't like the patient. That's different. But you probably
which
prefer
does happen
somebody to do more.
sometimes.
Uh-huh.
Which then that happens sometimes too, not liking them. Uh, but I
Yeah,
had
that's
some,
why like when I was working CPAP, I would err on the side of caution, and if I suspected, amphetamines there, like just give them benzo, calm down. Let's see, reassess after.
I've heard from some patients that you can use trazodone as like a rescue from LSD. Is does the pharmacology check out on that
As a rescue, what? A rescue for what?
as like a reversal agent for like acute LSD intoxication?
As if it's a 5-HT2A antagonist? That's a good
Mm-hmm.
question. I mean, I guess so. It is a 5-HT2A antagonist, but there's other 5-HT2A antagonists, right? Like cyproheptadine.
Mm-hmm.
I mean, if you wanted a cleaner one, but I don't know. That's a good point. I've never heard of that before. I'll look that up.
Yeah, it's interesting because some of the best harm reduction stuff comes out of just your your street psychopharmacologist.
Yeah,
Our patients are smart; they come up with some interesting things.
that's true. Well, a lot of our meds in psych they come out serendipitously, right? Where people kind of are good observers and they realize, wait, I was giving this med for this, but it helped with that, right? And then of course they do case studies about it. And then from case reports, it becomes, trials, open label trials to randomized placebo control trials, right? That's usually how it works, right? Enough case studies come out about a certain thing, people become interested in it, right? Who knows? Maybe if you mix mayonnaise with Haldol Deck, it'll cure schizophrenia, right? You never know. Someone could be eating a sandwich and some mayonnaise gets inside the injection. Now the patient is cured. But you never know. Who knows? But that's good to know, though. 5-HT2A antagonism. Yeah, interesting. That's why sometimes when someone's undergoing ketamine treatment, you have to stop the meds because if they're on very potent 5-HT2A antagonists, it actually makes the med not work. It makes the ketamine not work. I'm sorry. They don't get the full response. Kind of like someone taking a benzo and then going for ECT the next day, right? The benzo stops the seizure, so they need the seizure for it to work. Even lithium also, it's good to know. If someone's on lithium treatment and they're suicidal and they're going for ketamine treatment, they need to hold that lithium because lithium works on channels also, right? So if those channels are blocked, it interferes with the seizure and they're not going to get the full effect. Or they might have a side effect, an even worse side effect on the ECT with the ketamine there. So you want to make sure they stop that morning dose of lithium. They're doing ketamine. I'm doing ECT. I'm sorry, doing ECT. I've been lecturing since 9 this morning. Any other questions? Nope. All right. So just, before the final, I'll probably give you guys a summary of what to focus on. But I want you guys to kind of have a general understanding of everything, right? And it all ties in together. All right. Thank you very much for attending the class, and I'll see you guys next week. Take care.
Thank you.
Thanks so much.
You're welcome.